Hey NCS podcast listeners, this is your host Fawaz Al-Mufti from Westchester Medical Center. With the rapid evolution of neurocritical care, better comprehension of acute brain injury, as well as the relatively rapid influx of new medications, today more than ever, neurointensivists find themselves engaging and partnering with critical care pharmacists. From sedatives, hyperosmolar agents, vasopressors, or more specifically anti-epileptic agents, neurostimulants, or reversal agents, the pharmacotherapy of acute cerebral injury is undoubtedly complex and multifaceted. Hence, the NCS podcast decided to partner with the highly successful Pharmacotherapy of Neurocritical Care series, the PONS, in a limited release to cover pertinent pharmacologic topics presented by experts in the field of neurocritical care. Over the course of the coming months, you will hear a number of selected PONS talks, but please do let us know if there are particular topics you would like to be additionally covered. Without further ado, here is the PONS.
Hello everyone, and welcome to the Pharmacotherapy of Neurocritical Care series, or PONS. The PONS is a curriculum-based e-learning series comprised of various neuropharmacotherapy topics presented by experts in the field. My name is Kent Owusu.
And my name is Brian Gilbert. We will be co-hosting today's program, which is an inaugural program we are calling a mini PONS. We will provide concise review of neurocritical care topics of interest in 10-minute segments. For this session, there will be 3 segments to cover, all related to updated management of acute ischemic stroke. We will be interviewing a neurocritical care pharmacist and stroke program manager regarding trends in the literature on fibrinolytic therapy, management of symptomatic hemorrhagic conversion after fibrinolytic therapy administration, and then we'll talk a little bit about antiplatelet therapy for secondary prevention of stroke. It is our hope that this session will help answer many of the questions our members have about these important topics.
Our speakers today join us from Premier Health Miami Valley Hospital and Cedarville University in Dayton, Ohio. David Peters is an assistant professor of pharmacy practice at Cedarville University School of Pharmacy and a clinical pharmacy specialist in neurocritical care at Miami Valley Hospital. He is a board-certified critical care pharmacist. Shelley Reynolds is a clinical stroke program manager for Miami Valley Hospital's comprehensive stroke program. She's also a board-certified clinical nurse specialist. Hello to both of you, and thank you for joining us today. We've got a lot to cover, so let's get started. Our first topic surrounds the choice of fibrinolytic therapy for ischemic stroke management in eligible patients. Up until recently, this topic mostly revolved around the ideal candidate for fibrinolytic therapy, and as research continues to evolve, there appears to be an interest in more optimal options for fibrinolytic therapies that are safer for clinicians to administer. And so, David, can you please tell us a little bit more about our options and how we should think about them?
Yeah, thanks for having me. So currently, there's only one FDA-approved fibrinolytic agent for ischemic stroke, which is Alteplase. Alteplase is a recombinant human protein and is dosed as a bolus in a continuous infusion. There are 2 other fibrinolytic agents available on the market. There's Retaplase, and then there's the one we all want to talk about today, which is Tanectoplase. Now, Tanectoplase is a modified version of human TPA, and it's got a few key amino acid substitutions that provide favorable pharmacokinetic and pharmacodynamic variances in comparison to Alteplase. Regarding pharmacokinetics, the substitutions allow for a longer half-life of the agent, meaning that we can administer the medication as a bolus only. Regarding pharmacodynamics, the drug has a higher specificity for fibrin than Alteplase does, which theoretically is going to concentrate lytic activity at the location of the pathologic clot. It's also less likely to be inhibited by plasminogen activator inhibitor, which is going to give it a more durable effect. Now, these advantages translate to a pharmacologic agent that is more ideal for large vessel occlusion based on early research.
So tenecteplase has this distinct activity profile that is separate from Alteplase. David, it sounds like some of these characteristics could translate to improved care. Can you tell us a little bit about the history of TNK and how investigators have tried to identify its benefits in patients?
Yeah, so tenecteplase was first FDA approved in 2000 for use in myocardial infarction. Based on that MI data, it performed similarly to Alteplase in landmark cardiology trials, and it was easier to administer, which then naturally led to some excitement about its use in cerebrovascular occlusions. There was a registration of a dose-finding study by Haley and colleagues and a phase 2 open-label trial by Parsons and colleagues. Now, these trials displayed early efficacy of tenecteplase in comparison with Alteplase, and critically, they identified 2 key doses for evaluation of tenectoplase. That would be a 0.25 milligram per kilogram dose and a 0.4 milligram per kilogram dose. After 2015, we start seeing multiple prospective studies enter the literature. In 2015, the ATTEST single center study evaluated 96 patients who were randomized to either the 0.25 milligram per kilogram dose of tenectoplase or Alteplase. Then in 2017, the multi-center NORTEST trial evaluated 1,100 patients randomized to either the 0.4 milligram per kilogram dose of tenecteplase or Alteplase. These studies compared the safety and efficacy of tenecteplase to Alteplase and found them to be equivalent, with very similar rates of intracranial hemorrhage, as well as similar rates of functional outcomes in patients who received either drug. Now, after those trials were published, Dr. Campbell, who's actually appeared on this podcast before to discuss tenecteplase, led 2 recently published randomized trials under the name Extend IA-TNK Part 1 and Part 2. Part 1 directly compared tenecteplase 0.25 milligram per kilogram to Alteplase in 202 patients. In Part 2 of the trial, tenecteplase 0.4 milligrams per kilogram was compared to 0.25 milligrams per kilogram in order to establish if there was an optimal dose between these 2 different doses. 150 patients were enrolled per group, and the study concluded that there were no differences between the 2 dosing schemes. As such, the 0.25 milligram per kilogram dose does seem to be the more conventional dose, at least here in the United States.
Wow, David, thank you for that brief overview of some key clinical trials. I can think of a meta-analysis and some more recent studies that come to mind for the topic. So what are some more recent trials that have been published, and have they detected similar safety and efficacy findings?
Yeah, great question. At this point, it seems like we're finding out new information about tenecteplase each month as more and more data are published, and it's exciting. But overall, here are some of the things that we observed. There was a key meta-analysis published in Stroke that reviewed randomized trials published before April of 2020. They collated 4 randomized trials with 433 patients who received either tenecteplase or Alteplase for large vessel occlusion. They found that tenecteplase patients were more likely to achieve a modified Rankin scale of 0 to 2, successful recanalization, and functional improvement. Basically, patients were more likely to be functionally independent at 90 days. There was no difference in mortality, and within this meta-analysis, there was very little heterogeneity, signifying that the trials all had similar trial outcomes and could be combined for comparison in a valid way. Now, those were trials before April of 2020. And since April of 2020, we've had a number of key trials that we could also discuss. There's the TASTE-A trial, which compared about 100 patients who were randomized to either Alteplase or the 0.25 milligram per kilogram dose of tenecteplase on a mobile stroke unit. And the study found that the perfusion lesion volume was smaller upon hospital arrival in the tenecteplase group compared to the Alteplase group, and they had no cases of symptomatic intracranial hemorrhage in their population. They also noted that time to thrombolytic therapy was decreased in the tenecteplase group. There's the ACT trial out of Canada, which is a randomized trial that's not yet been published, but there was early data that came out of the European Stroke Conference that suggests that tenecteplase is non-inferior to Alteplase, and it's in the largest trial to date with 1,600 total subjects. Now, with those 2 trials being positive, there is one trial that breaks the mold. There's the NORTEST 2 randomized trial, which was published recently, and it was actually stopped early because there was concern for increased hemorrhage in the tenecteplase group. Specifically, rates of hemorrhage were 21% in the tenecteplase group and only 7% in the Alteplase group. In addition, the functional outcomes that they reviewed favored Alteplase. Now, for this trial, it's really important to note that they did use the 0.4 milligram per kilogram dose rather than the 0.25 milligram per kilogram dose. Since then, the investigators have actually dropped the dose of tenecteplase to 0.25 milligrams per kilogram in their trial, and they're going to continue their trial with this new lower dose. Now, I want to be really clear. Right now, the quality of evidence is still very low with tenecteplase, considering how few patients have been treated in randomized clinical trials. Just to give a comparison, the NINS trial was the landmark trial that led to the FDA approval of Alteplase, and they enrolled 624 total patients. Now, most published studies for tenecteplase contain far fewer patients, though there is new data emerging, and there are several trials that are larger. Now, all of this new data need to be monitored very carefully so that we ensure that we're always providing high quality care for our patients.
Well, that was great, and thank you for that overview. And to summarize, if I may, it sounds like we've observed effectiveness of tenecteplase for stroke, and that it may be more preferred with respect to robust thrombolytic activity. We're still waiting, however, it seems, on more generalizable data in a heterogeneous mix of patients with sizable volumes. So that begs the question, do we see an increased bleed-in risk associated with tenecteplase, or do we not really have concerns with that regards?
Yeah, that's the key question. That's what we'd love to know the answer to. When we look over at all of the literature, you can start by looking at the myocardial infarction data. Now, in those trials, there were generally lower bleeding rates that were reported for tenecteplase, but those were specifically non-intracranial hemorrhage bleeding. So tenecteplase had a lower risk of bleeding compared to Alteplase for non-intracranial hemorrhage. However, the data had never shown any difference in bleeding rates for intracranial hemorrhage between Alteplase and tenecteplase. But we're not treating MI, we're treating stroke, so we need to review the stroke literature. Now, the meta-analysis that I described before found no difference in intracranial hemorrhage between the agents. And to date, to my knowledge, no comparative study has shown a decrease in symptomatic intracranial hemorrhage for tenecteplase when compared to Alteplase in the setting of acute ischemic stroke. There are a few signals in the literature that suggest an increased risk of symptomatic intracranial hemorrhage for tenecteplase, which is specifically going to be NORTEST 2. Remember, they did publish a statistically significant increase in intracranial hemorrhage compared to Alteplase. Specifically, large parenchymal hematomas, referred to as PH type 2 hematomas by the Heidelberg criteria, occurred in 8% of tenecteplase patients and only 1% of Alteplase patients. That warrants caution with the 0.4 milligram per kilogram dose. This is also very similar to one of the trials we discussed earlier, the Extend IAT&K Part 2 trial, which compared the 0.4 milligram per kilogram dose and the 0.25 milligram per kilogram dose. A non-statistically significant difference was observed with higher symptomatic intracranial hemorrhage in the 0.4 milligram per kilogram group. Specifically, it was 4.7% in that group versus 1.3% in the 0.25 milligram per kilogram group, although that was a much smaller sample size than NORTEST 2. But like any new therapy, sites interested in using tenecteplase do need to monitor their bleeding rates. Right now, the literature suggests that the 0.25 milligram per kilogram dose should result in no greater risk of bleeding compared to Alteplase, at least based on what we see now, though this should be limited to application in populations that were studied in these reference trials. And as always, we've got to critically evaluate each patient who comes to our institution for risk factors associated with symptomatic ICH, and we should be conducting risk-benefit analysis for each use of fibrinolytic and tailor it to the patient who's right in front of us.
Yeah, so a lot of pragmatic benefits there discussed, and with tenecteplase's unique activity, there does seem to be some potential benefits there. Shelley, how do these differences in dosing, administration, and sort of the efficacy of tenecteplase translate to patient care?
So while Alteplase is a great treatment for ischemic stroke, tenecteplase does have a few pragmatic advantages that should be considered when a health system is evaluating their preferred fibrinolytic. The primary benefit is probably in administration. Time is brain for stroke patient, and from the time the patient calls 911 until they receive an intervention for stroke, each minute matters. Alteplase is given as a 1-minute bolus and a 59-minute infusion. That requires a smart pump and time to program it. Not only that, but patients who are transferring to a different hospital or to angiography for thrombectomy will need to be transferred with medication infusing. Alternatively, tenecteplase is given as a single bolus. Simply mix, measure out the dose, and administer the fibrinolytic. It simplifies the process for transferring and may decrease door-to-needle time or door-to-groin time. One consideration, in contrast to Alteplase, if there are dosing errors with tenecteplase, the opportunity for adjustments will have passed. It's a one-and-done dose. From a telestroke perspective, it made sense to switch all sister hospitals to using tenecteplase at the same time as the hub. The outlier here are spoke sites who have contracts with centers for telestroke but are not in our system. This brings up unique challenges of formularies, staff training, etc. Approaching implementation on a hospital-by-hospital basis makes sense. Partnering with these small rural hospitals to provide guidance, share order sets, and develop staff training will help set those hospitals up for success.
Thank you, Shelley, for that critical perspective. We know that stroke is a disease state with a high degree of regulatory scrutiny. There are also high standards for practice and competitive benchmark targets. So what are some considerations for sites interested in utilizing tenecteplase for stroke?
Great question. From a regulatory standpoint, you will always be held to the policies, guidelines, and order sets that your program has adopted and published for your staff to reference. If there is a recognized nationally supported guideline, such as the 2019 Acute Ischemic Stroke Guidelines from AHA to reference, your program leadership can decide the route that your program takes. Accreditation reviewers will inquire about how this decision was reached, who was involved in that discussion, and ongoing review of the practice change. Furthermore, institutions will need to determine if they allow the use of both tenecteplase and Alteplase. If so, there are a few considerations. First, if we use the abbreviations TNK and TPA, They do sound alike. Using the full name Tanectoplase and Alteplase may decrease ordering errors compared to using the abbreviation. Second, those sites using Tanectoplase must recognize that the drug manufacturer does not replace mixed Tanectoplase. The manufacturer currently replaces Alteplase vials that are mixed, but not given for a clinically relevant and documented reason. But since Tanectoplase is not FDA indicated for stroke, the manufacturer will not replace Tanectoplase vials. Therefore, to avoid drug loss, the medication should only be reconstituted when ready to administer. Finally, sites should recognize that the box the Tanectoplase is packaged in actually has a dosing chart for myocardial infarction dosing. This dosing is higher than what would be given for a stroke patient. So this chart needs to be removed or covered up to avoid a dosing error. A best practice could be having 2 nurses review the dose in the electronic health record prior to administration.
Yeah, so there's a lot of moving parts when it comes to the decision of which fibrinolytic to use. And to the listeners, we've had some offline discussions with Shelley and David, and we know that you have implemented this at your own facility. So what are some key elements that were used to help sustain and ensure good outcomes after the switch?
Yeah, it was a multi-step process and we had a lot of stakeholders involved. But basically, when we added Tanectoplase to our stroke order set, that was in October of 2020. We based that decision off of the Extend IA TNK Part 1 data. And as such, we suggested that it be used in patients who were being considered for endovascular thrombectomy. But really, we allowed that our providers in the stroke or emergency department to select either Alteplase or Tanectoplase at their discretion. Now, we had our first use just about a week later. And after a year of use, we expanded our criteria and we took away that suggestion that it was for patients specifically with large vessel occlusion. And we allowed it to be used in any patient with an acute ischemic stroke, basically at the discretion of the provider. We've administered it to about 90 patients over this time frame. Now, part of that experience means that we've made sure that we've audited, and we audit every 6 months and we review that data specifically with our pharmacy and therapeutics committee, as well as we have an emphasis on safety data, which are periodically reviewed by the stroke team. Alongside that, we're working on a retrospective review with a historical comparison to Alteplase patients who were candidates for thrombectomy as well. At this point in our review, we've compared 144 Alteplase patients to 42 patients who were administered Tanectoplase. Early findings from our study suggest that we have a 30% decrease in our time to groin puncture, as well as a 25% decrease in time to recanalization when we use Tanectoplase. We've also observed improvements in modified Rankin scale, as well as a decreased length of stay in our Tanectoplase group. So right now, early results are encouraging, but it was a multi-step process, and there were a lot of people at the table to help make the decision and continue to monitor and make sure that we're providing high-quality patient care.
This has been a great discussion so far on the unique opportunity in stroke management. Fibrinolytic use in stroke has provided a massive benefit for patients over the last few decades related to functional improvement. However, these medications aren't without risks. So given all of the discussion surrounding intracranial hemorrhage, let's talk about symptomatic hemorrhagic transformation. David, should we think about this in a specific way, and how do we approach overall management of symptomatic hemorrhagic transformation in the setting of thrombolytic therapy?
Yeah, unfortunately, hemorrhagic transformation may just come with the territory of using fibrinolytic therapy for stroke. But when we have any discussion on symptomatic hemorrhagic transformation, we've got to start with definitions. All intracranial hemorrhages are not created equal. In fact, after mechanical thrombectomy, the incidence of any radiologic intracranial hemorrhage could be as high as 30 to 40%. Now, a vast majority of those are asymptomatic and simply occur when we reperfuse infarcted tissue. Now, because asymptomatic hemorrhage does not routinely impact our outcomes, we need to identify and classify hemorrhages in a clinically meaningful way. And this has been debated over the last 2 decades. Now, an optimal definition of hemorrhagic transformation is going to consider both clinical worsening associated with the bleed, as well as radiologic presence of bleeding. Now, clinically, a symptomatic hemorrhage is just defined as intracranial bleeding that directly causes a worsening of the NIH stroke scale. Radiographically, there are several different classifications. The ECAS-2 classification system distinguishes hemorrhagic infarction from parenchymal hematomas. Both of those have 2 types based on severity. Hemorrhagic infarction, or HI hemorrhages, refer to small amounts of blood within the infarcted territory that have no mass effect. Parenchymal hematomas, or PH hematomas, generally exhibit mass effect and can extend beyond the infarct location. Now, recently, the Heidelberg classification system expanded on these criteria for a more robust classification of hemorrhagic transformation And it does allow us to standardize definitions for research or clinical purposes. Now, there are limitations of the Heidelberg classification system, including possibly underreporting smaller hemorrhages that cause a clinical worsening.
All right, so brass tacks, you've got these definitions and these interventions. What is the expected incidence of clinically relevant hemorrhagic transformation?
Yeah, that's the question that everybody wants the answer to. If we focus on just symptomatic intracranial hemorrhages, which require urgent attention and require interventions, then the incidence would be highly dependent on how we treat the patient's stroke and the severity of their stroke, along with other patient-specific factors. If we focus on the population of patients who only receive fibrinolytic therapy, the rate of hemorrhage is likely between 2 and 7%. Now, there are different risk factors that would impact exactly what the percentage might be, and those risk factors would include advanced age, greater stroke severity, atrial fibrillation, diabetes, and hypertension, among a few others. Now, there's also an increase in hemorrhage in patients who undergo mechanical thrombectomy, and in particular for patients who receive both fibrinolytic and endovascular therapy. These patients experience symptomatic hemorrhage at a rate between 5 and 7%, according to a 2017 meta-analysis.
Okay, so it sounds like most intensive care practitioners who monitor patients after thrombectomy and fibrinolytic therapy will inevitably encounter this complication at some point. And so what are the current guideline recommendations for management, David?
Yeah, there's a few guidelines that you can pull for some direction on management. The Neurocritical Care Society has guidelines for the reversal of anticoagulants, antiplatelets, and fibrinolytics. It's a great resource. That's an overview for this topic, and it was published in 2016. There's also a 2017 position paper on the management of hemorrhagic transformation published by the American Heart Association, also was endorsed by the American Academy of Neurology and a couple of the key neurosurgery academies. Finally, the American Heart Association Acute Ischemic Stroke Guidelines from 2019 address the management of hemorrhagic transformation. All of these papers outline pharmacologic therapies that would be indicated if your patient experiences hemorrhagic conversion.
All right, so before we discuss therapies, let's review the time frame for coagulopathy after administration of the fibrinolytic. When did the majority of hemorrhagic transformations occur for patients who receive thrombolytics?
Yeah, many of our listeners are going to be familiar with the plasma half-life of Alteplase or Tanectoplase, which are about 5 minutes and 25 minutes respectively. And it would be great if that was the only time patients were at risk for bleeding. But unfortunately, the terminal half-lives of these agents are much longer, and the risk for bleeding extends for up to 24 hours. Now, early research reviewed laboratory abnormalities after administration of Alteplase and found that the highest bleeding risk actually occurred between about 1 and 4 hours after administration of the medication. Most laboratory abnormalities that they reviewed resolved at approximately 24 hours after receiving the dose. Therefore, patients are at the highest risk of hemorrhagic transformation shortly after fibrinolytic infusion and may continue to be at risk for up to about 24, maybe at max 36 hours after receiving the dose. Furthermore, some researchers from Johns Hopkins have identified that the majority of symptomatic hemorrhages will occur within 12 hours of receiving Alteplase. In this particular study, 81% of patients who had a hemorrhage experienced that hemorrhage within 12 hours, with the majority of hemorrhages occurring between 4 and 8 hours after administration of Alteplase. So if your patient experiences hemorrhaging outside of about 24 hours, it's likely that no reversal is likely to be indicated, as the risk of pathologic clot may outweigh the benefit of reversal agents.
All right, it's 3 a.m. My patient received a thrombolytic, tenecteplase or Alteplase. It's 3 a.m. I'm a resident. What do I do?
Yeah, it's always 3 a.m. when these things go down. And honestly, at this point, your options are a little limited and the research is somewhat sparse. Now, in the guidelines, the recommendations for reversal are based on weak evidence and expert opinion. The therapies available are cryoprecipitate, concentrated fibrinogen, and anti-fibrinolytic agents like tranexamic acid or aminocaproic acid, along with blood pressure management and intracranial pressure reduction when those are applicable. Now, our goal of therapy is to prevent hematoma expansion. And based on current evidence, our key player for hematoma expansion is fibrinogen serum concentration. It has been observed that after Alteplase administration, fibrinogen concentration can decline sharply, and that levels lower than 200 milligrams per deciliter can increase risk of hemorrhagic transformation. Now, the most effective means to supplement low fibrinogen are cryoprecipitate at a dose of 10 units as soon as feasible, or fibrinogen concentrate, which is also known as Restab. It's a lyophilized human fibrinogen, which can be administered but may not be available at all institutions. Cryoprecipitate does require that you type and screen the patient and must be thawed and is a limited resource. Now, in most institutions, cryo will be administered as a pooled unit, where one pooled unit is 5 individual units of cryoprecipitate. So if your electronic health record defaults a dose of either 1 or 2 units, that's going to be equivalent to 5 or 10 individual units of cryoprecipitate, respectively. And again, our dose based on guideline recommendations is 10 units of cryoprecipitate. Concentrated human fibrinogen has the benefit of a more rapid administration because it's not typed or thawed, but it is costly and it has less data for this indication. There is a 2020 paper which suggests that this medication can rapidly correct for hypofibrinogenemia, which should theoretically benefit the patient. The paper included a very small population, but did note a 12.5% rate of thromboembolic events, with the majority of events occurring 1 week after treatment with fibrinogen. So that does confound the causality of what caused those thromboembolic events. Now, generally, one should immediately administer one of these agents and then order a serum fibrinogen level about an hour later. If the level is persistently below 150 milligrams per deciliter, you can get a repeat dose of cryoprecipitate or fibrinogen, or at least consider that, though again, based on very low quality of evidence and expert opinion. Now, there are other therapies that have been trialed, and these are a class of drugs known as anti-fibrinolytic agents. There are 2 drugs in this class, tranexamic acid and aminocaproic acid. Now, these drugs work by inhibiting the binding of plasmin to fibrin. This can stabilize a clot and prevent the breakdown of a clot from activated plasmin. They also have the ability to displace plasmin from fibrin. Therefore, they have a proposed benefit for patients who have pathologic bleeding related to Alteplase or Tanectoplase. Dosing for these agents for this indication is somewhat variable and may vary from institution to institution. Now, interestingly, these drugs will not impact coagulation time, so they do have a lower risk of clot development as a side effect, which is nice. Per the guidelines, these agents are reasonable considerations for all patients, but they're particularly useful when patients refuse blood products or blood products are not available. As always, clinicians should weigh the risk of thromboembolic events with the benefits of reversal therapy and use institutional protocols in order to facilitate more rapid treatment of hemorrhagic conversion.
Wow, David, thank you for that yet again comprehensive overview. I'm just amazed about how many clinical inputs and patient-specific considerations really have to be, considered in making these very relevant and critical clinical decisions. Shifting gears a little bit to Shelley. So given the incidence of hemorrhagic transformation, we should always be striving to provide the best and safest patient care. And so Shelley, are there any best practices for reviewing hemorrhagic transformation and process improvement related to fibrinolytic therapy?
Well, that is a loaded question. So there are a variety of process improvement tools that we're probably all familiar with that could be used. The key element is that the right people are involved in the discussion. One method that we found that has worked for us is scheduling a regular time to meet and discuss these cases as a team. Stakeholders that could be considered are your quality department, your stroke attending, your neurocritical care provider, interventionalist, a neurosurgeon, if that's applicable, and stroke program manager, and definitely pharmacy. This review can consist of a brief overview of the case, any potential deviations from protocols such as blood pressure management prior to administration, and complete inclusion/exclusion criteria consideration, for example. Reviewing pertinent imaging paired with any documented clinical findings allows the team to retrospectively classify these using the Heidelberg criteria. This process is important for 2 reasons. It becomes an official process improvement structure for this population of patients. Reviewing and implementing improvement strategies will hopefully translate to improved patient outcomes. Additionally, from a regulatory standpoint, this is often a topic of discussion during certification reviews. It bodes well for your program to have a documented ongoing review and process improvement plan for these cases.
Any final tips on collaboration across disciplines when we're monitoring and treating these hemorrhagic conversions, or any other complications from fibrinolytic use?
So 2 things I think worth mentioning are including angioedema management medications in your fibrinolytic administration order set, as well as having fibrinolytic reversal order panels to guide the provider in getting treatments ordered and administered quickly. Also, communicating with your blood bank team member. If a patient is experiencing a hemorrhagic transformation, this is a medical emergency. They should be ready to thaw and transport cryoprecipitate in a rapid fashion. Make sure you understand how the orders for cryo are placed and use order sets when possible to facilitate rapid reversal.
So hopefully by now our listeners feel more equipped to manage fibrinolytic therapy as well as its complications. So at this point, let's shift to our final topic for the presentation and discuss antiplatelet therapies. Secondary prevention of stroke is a major emphasis for care. Even with optimal therapy, around 5 to 10% of patients can experience a new ischemic stroke within 30 to 90 days after initial event. So David, what are we doing to prevent this complication?
Yeah, Kent, there's been a series of landmark trials related to secondary prevention of stroke. For cardioembolic strokes, anticoagulation continues to be the mainstay. Now, embolic stroke of undetermined sources and atherosclerosis tend to be a little more controversial to manage. So we'll focus on those etiologies. Anticoagulation for cryptogenic or atherosclerotic strokes tends to increase bleeding risk without significantly altering risk of recurrent stroke when compared to antiplatelet therapy. Now, there's ongoing trials like Arcadia, which is seeking to identify if there's a population of patients without atrial fibrillation who do benefit from anticoagulation, but those results are not yet available. As such, antiplatelet therapy really is our main focus. Now, our pharmacologic options are aspirin, dipyridamole, and the P2Y12 inhibitor class. Aspirin's really affordable and it's well tolerated, and it tends to be a mainstay of our therapy. On the other hand, dipyridamole is taken twice a day, and it can be expensive even though it's been around for a while. It's also got a lot of adverse effects and predominantly causes a lot of headaches, so that limits its use. Now, in the P2Y12 class, there's 3 P2Y12 inhibitors: clopidogrel, prasugrel, and ticagrelor. Now, prasugrel does have a black box warning stating that there's an increased risk of intracranial hemorrhage in ischemic stroke patients, so we're going to throw that one out entirely. And that means our choices are really limited to clopidogrel and ticagrelor. Now, between these medications, there's a few really key differences. Clopidogrel is a prodrug, and it's got to be activated via a 2-step process through hepatic enzymes. There is a subset of individuals who actually have genetic loss of function alleles for these enzymes, and specifically CYP2C19. And these patients do not activate clopidogrel and therefore lose some of the benefit of the medication. These genetic attributes are seen more commonly in Eastern Asian populations, where a single loss of function allele can be found in up to 60% of the population. Now, clopidogrel irreversibly inhibits the P2Y12 receptor, and therefore it maintains an antiplatelet effect for around 5 to 7 days after it's administered. Finally, it is available as a generic, and it's only taken once a day, which are benefits of clopidogrel. On the other hand, ticagrelor is a reversible inhibitor of P2Y12, and it's got about a 7 to 8 hour half-life. As such, the effect of the drug wears off more rapidly, and it does need to be taken twice a day. There are no major genetic interactions with ticagrelor, which is a huge strength, and it's available under the brand name Brilinta, so it can be costly for some patients, and particularly those who are uninsured. Now, you can use different platelet function assays that may be available from your lab as an objective way to try to identify if patients may not be able to tolerate clopidogrel or may have a poor response to clopidogrel. And that could also help to identify patients who would benefit from ticagrelor and maybe some additional workup.
All right. With all these options available, the key question then shifts to which medications we should use, how many medications we should give, and for how long. Do you have any insights to share for these kind of burning questions for our listeners?
Yeah, Brian, thankfully, we do have a couple of landmark trials that have outlined at least a general approach to antiplatelet therapy after acute ischemic stroke. To start it all off, there were 2 large studies, CAST and IST, from the late 90s that identified that early initiation of aspirin after stroke decreases the risk of ischemic events with only a minor increase in major bleeding. So we know we want to start antiplatelet therapy early. The next 2 decades of research have helped us outline the optimal choice of antiplatelet therapy. Now, the CHANCE trial evaluated an Asian population with minor stroke or high-risk TIAs who had received dual antiplatelet therapy, which I'll refer to as DAPT, or aspirin monotherapy for secondary prevention of ischemic events. The study found that dual antiplatelet therapy for 21 days decreased ischemic events without increasing the risk of bleeding in this particular population. The next key trial to talk about is the POINT trial, and it followed the CHANCE trial to evaluate the same question in a different patient population. Importantly, the POINT trial also utilized DAPT for 90 days instead of the 21 days, which was utilized by the CHANCE trial. The findings of this study were super interesting. Ischemic events were decreased in the DAPT therapy arm. However, patients who received DAPT also had a significant increase in major and minor bleeding. Now, I'm going to encourage the listeners to go and review the time to event graphs on figure 2 of this trial, because a picture is really worth 1,000 words for these findings. Now, what you'll notice if you look at this graph is that there's a benefit for ischemic event reduction that occurred almost entirely in about the first 3 weeks of therapy. And in contrast, the risk of hemorrhage was seen after the first week of therapy and actually increased over a period of 30 to 90 days. So what we can conclude is that DAPT is beneficial in this critical period of maybe about 3 to 4 weeks after an ischemic event. But if we continue DAPT beyond 30 days, we're going to see an increased risk of hemorrhage in many stroke patients.
Really love the overview of CAS-IST and your attention to detail for POINT. David, have we had any clarity related to the place of ticagrelor in ischemic stroke patients?
Yeah, that gets to be a little tricky, but thankfully we've got 2 recent trials that give us a little bit of insight on ticagrelor in this indication. The Alteplase trial studied DAPT with aspirin and ticagrelor compared to aspirin alone for 30 days after minor stroke or TIA patients. Similar to the POINT trial, there was a benefit observed in the DAPT group related to decreased ischemic events with an increase in major bleeding. Ticagrelor is therefore appropriate as an agent to select for DAPT in conjunction with less than 100 milligrams of aspirin, and it's got an FDA approval for this indication. So the key question, though, is how do we choose between clopidogrel and ticagrelor as our P2Y12 inhibitor for DAPT? The CHANCE-2 trial was recently published, and it's a really unique trial which compared the 2 different P2Y12 inhibitors head-to-head as part of DAPT therapy. So one group of patients received aspirin and clopidogrel, and one group of patients received aspirin and ticagrelor. Now, the trial was organized in China, where we said up to 40 to 60% of patients could have a loss of function allele related to activation of clopidogrel. Now, as part of the inclusion criteria, patients actually had genetic tested, and they were included only if they had a loss of function allele. So therefore, it was hypothesized that the ticagrelor group would actually experience fewer ischemic events because the patients receiving clopidogrel would have decreased activation of clopidogrel to its active form. When we look at the results, we see that recurrent stroke occurred in 7.6% of clopidogrel patients, compared to only 6% in the ticagrelor group. And that's a number needed to treat of about 63. So I honestly expected it to be a little higher, but there are alternative hepatic enzymes that can activate clopidogrel other than CYP2C19. When you looked at bleeding, it was actually identical between both groups. So we can conclude that patients with confirmed loss of function alleles can benefit from the use of ticagrelor, but the treatment effect was small and the cost of ticagrelor remains higher than clopidogrel for many patients.
And, so for our listeners, we know that a lot of our stroke care is standardized, and this is no different. So what guidance do we have, Shelley, from regulatory bodies related to initiating antiplatelet therapy in the hospital setting?
So things that we look at from a stroke program management standpoint are antiplatelet therapy must be started by hospital day 2. After fibrinolytics, you must wait 24 hours to start aspirin. That's just part of our American Heart Association guidelines. So on our order sets, we default aspirin orders after fibrinolytics to begin the day after the order set is utilized. By doing this, it allows for at least a 35-hour window after a fibrinolytic is given for safety. And that makes sure the aspirin is given by the end of the hospital day 2 as well.
All right, so Shelley, to just bring it home for us, do you have any best practices for looking at the selection of antiplatelet agents and then following patients as they transition from the hospital to their homes in the outpatient setting?
A couple of things come to mind. So development of order sets as a stroke program with the different players on your team allows for comprehensive review of these drugs. One of the things that we have done is looking at these on an annual basis as review them. And we have the ability with a software program we use to look at what orders were used, how often we're utilizing those different medications. And that has helped us and been beneficial in reviewing those order sets and then moving forward and changing those on an annual basis. As far as following up goes, our first line of defense is tracking these patients and following up with them at their stroke follow-up appointment in our outpatient stroke clinic. We do have a stroke nurse navigator, which lots of systems have. That person will identify these patients while they're in the hospital and add comments to their appointment notes in the stroke clinic schedule. This will allow the providers to review this information at their follow-up appointment. This ensures that we're not keeping patients on dual agents longer than intended.
Thank you, Shelley. I really love your holistic, patient-centered, intentional approaches. So just to ensure that things are not missed as patients transition from the inpatient setting, but also beyond that into their homes and other post-acute care locations. Well, that brings us to the conclusion of our session today. We would like to thank our distinguished guests, David Peters and Shelley Reynolds, here today for their wonderful insights. Thank you all for listening to our inaugural mini PONS. And don't forget to check out our full PONS modules online on the NCS website. Until next time, I am Kent Owusu.
And I am Brian Gilbert, and signing off.
Thanks for listening to the NCS podcast. The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. Our production staff includes Tariq El-Maghribi, Andrew Barishmet, Leonid Groisman, Atul Kalanuria, Lauren Kaufman, Cassie Cronfield, Holly Ledyard, Lindsay Marchetti, Alexander Reynolds, Lucia Rivera-Lara, John Rosenberg, Jason Siegel, Zachary Threckeld, Teddy Yoon, and Chris Zamet. Our administrative staff and senior producer is Bronnie Rousseau. Music by Mohan Kadapali from the University of Miami Division of Neurocritical Care. If you like our show and want to learn more about us, check us out on Twitter, Facebook, or LinkedIn. The NCS podcast is available on NCS On Demand, iTunes, and wherever you get your podcasts. I'm Fawaz Al-Mufti, and thanks for listening.